Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and entire tri-state community. We're going to be talking about pediatrics today. When you think about pediatrics, we're going to talk about it in a little different setting than most of us think about. We're going to talk about it in the hospital. Kids get frightened in the hospital. Parents get frightened when their children need to go to the hospital. And we have a wonderful guest who's really going to help us navigate how it is to go to the hospital when you're a child, and for the parents, and realize what's going on, especially during this COVID era that we're in right now. So my guest is Dr. Allan Mendez, someone who's very special to me. She's been the pediatrician to my children, so someone that I know for many, many years. He's the chief of ambulatory pediatrics at Richmond University Medical Center, and she was just recently named treasurer of the Richmond County Medical Society. I'm a past president of that organization, and has been trained both in internal medicine and pediatrics. So you are a plethora of information for all of us in our wonderful community and our audience that's out there. So what we're going to do is talk about pediatrics, but we're going to talk about it in a way that's a little bit different. So tell us a lot about what's going on in the hospital with pediatrics. And maybe even beforehand, tell me a little bit about what's the training of someone who's a pediatrician, and in your case, an internist. So tell us from your medical school on. So tell us what you had to do to get here.
So basically, to become a physician, you have to do your bachelor's degree, and some people do other training and then apply for medical school. And that's usually 4 years. And then after you finish, you apply for residency. In my case, I couldn't make up my mind between medicine and peds. I love them both. I wanted to do family medicine, but in an urban area. So I thought that medicine and pediatrics or med-peds program would be better for me because it would train me more academically, and it would be perfect for an urban setting. So I did a residency for 4 years. That included 6 months each year, one for medicine, one for peds. And, it was a wonderful experience, and, it really gave me the building blocks to do the work that I do now.
And you are a wonderful physician, as I said, someone who took care of my kids for many years. And it's truly a pleasure and an honor to know you, Anna.
Thank you, Allan.
So we're going to talk about the hospital. Mm-hmm. Why do children need to be in the hospital? Well,
usually most of pediatrics is an outpatient specialty, especially nowadays. We take care of most things in the outpatient setting. But there are some things that really need to be taken care of in a hospital. Things that can be, put a kid's life in danger, or the possibility of. So when it comes to kids, we think of them in different stages. So infants are very fragile in terms of their immune system. So many times when they have fever, when they have simple symptoms like vomiting or diarrhea, we really need to look into it and see, that they're not very dehydrated, that they don't have an infection that is hard to diagnose. So sometimes pediatricians might have to send them to the hospital to get further testing.
What's an infant? What age group?
So an infant is anyone from birth to less than 12 months of age. Mm-hmm.
And then other groups, you said, so after infancy?
So after infancy, you have early childhood until around 5. And in those kids, their immune system is very developed. They really, fever and regular symptoms, it's easier to take care of in the outpatient setting. But some of them, a few of them can end up having something simple like a upper respiratory infection become something more concerning, where they might need IV medication or oxygen supplementation, and things like that need to go into the hospital. And surgical things can come up that are acute and need to be taken care of in a hospital.
Like what? Tell us, what kind of surgeries do kids usually?
Usually at that age, some kids can have appendicitis is a big thing. Always trying to rule that out. Interception in infants, which is kind of like telescoping of the intestine, that can happen in kids, and they can present, with vomiting and lethargy and things that might look simple, but that you have to look into it. So, what I usually tell parents is that parents know their kids. When you feel like your kid needs to be seen, always call and get seen. And the earlier the age, the more that you should listen to that, because that would help pediatricians to kind of, hone in into what is going on.
Tell us about we'll start with tonsils. Now, when I was a kid, everybody had their tonsils taken out, and then
yes.
nobody had their tonsils taken out. Now people are having their tonsils taken out again. So tell us about your patient. When did you decide to send them to an ear, nose, and throat specialist for possibly a tonsillectomy?
So basically, I'd had my tonsils taken out when I was little, just because I had sore throats and throat infections. But that's not the case anymore. You have to have a certain number of throat infections a year to qualify to have your tonsils taken out for that reason. But the main reason we take tonsils out now is sleep apnea. So when a kid snores, right? And it's that question that I always ask parents, and they don't have to be obese. For kids, it's really, you see them, their mouth breathing, their snoring. If parents tell you that, I always send them to an ENT. And what they will do is they will take a look, scope them, and they will usually will send them for a sleep study. And if the sleep study shows that they have sleep apnea, the ENT will decide as a team with us, if according to the results, if this kid needs tonsils out. So I think the number one reason why kids get their tonsils out nowadays is sleep apnea.
So tell us, when you say scoping, I mean, just for our audience, most children won't sit still for something to be put down their throat. Most adults won't either.
I know.
So tell us, how do you do a scoping, or how do the ear, nose, and throat doctors do a scoping on a child?
Yeah, well, I've seen them do it in the hospital, and I've had actually one done myself as a teenager, because I had a nodule in my vocal cord. But they go through the nose, and they take a look, and they're very good at what they do. It's a quick thing, and they can see the anatomy. They can see what's obstructing, if they're obstructing, and not only the tonsils, also the adenoids that are behind the back of the nose.
And as a neurologist who works with you at the hospital, Richmond University Medical Center, when I'm called into the pediatrics, and usually I don't see children, but usually there are kids who have seizures.
Yes.
So do you have a lot of children with epilepsy winding up at the hospital?
Yes, that's absolutely. Thank you for bringing that up. That's actually one of the other reasons why kids end up hospitalized. There's something that's not really a seizure, which is febrile seizures, that usually happen in kids from 6 months to 6 years of age. When they have a fever, they might have a seizure, usually for no more than 15 minutes. It's generalized and very classic. If that's what a kid gets, and usually runs in families, well, you decide when they come to the emergency room if it's a febrile seizure. If it's anything other than a febrile seizure, usually want to admit kids to work them up and see why they have them. And as you know, as a neurologist, when a person has a seizure, it's the best time to catch the changes that you might see in the brain, an
EEG, brainwave test, of course.
Absolutely. So that's what we do. We do video EEG, where the kid stays in the hospital. They get their brain waves. You can see what they're doing as you see the brain waves, and that's the best way we have to diagnose seizures. And just like with adults, sometimes you catch it, you don't. But definitely, that's one of the biggest reasons why we admit kids to the hospital.
Especially with the commitment to medications. As a neurologist, we see a lot of people with seizures, whether they're adults or young adults or children. And the idea is whether to commit someone to an anti-seizure medicine, so we use the word anti-epileptic drug, for a long period of time, we really do need a lot of the confirmatory evidence that we get during those hospitalizations.
Absolutely.
So tell me a little bit about asthma. I mean, when I go to the emergency room, there's a little pediatric portion of it. We always see the young children wheezing and having a hard time moving air, as we say. And it seems like a lot of children with asthma, very advanced asthma, sometimes get admitted to the hospital.
Absolutely.
So tell us a little bit about what parents should look for with asthma.
So that's a great question, because in my own practice, in the last 5 years, I've been part of the Asthma Coalition of Staten Island, actually the chairperson for that Asthma Coalition. And we did, one of the things that we want to do with asthma is we want to avoid kids from getting to that point. Because when they get to that point, it's absolutely very dangerous. And the thing with kids is that they change quickly. And you have to, it's not like adults, especially the younger they are. They adapt, and then they can change quickly. So you want to make sure they don't get to that point. So when they, if any kid is wheezing and seems to have difficulty breathing, absolutely you should take them to be seen by a physician. We did some changes in our practice working with the hospital, in which we decreased the amount of kids that ended up in the hospital by more than 25% from our practice. And also, and we did that by, once they left the hospital, and they came to our practice, making sure that we follow them every 3 months, that they had their asthma medications, that they saw the pulmonologist, that they saw the allergist, because asthma can be multifactorial. For most of my experience, especially practicing in the North Shore, there is a lot of allergies, especially indoor allergies, especially to roaches and mold. We actually have worked with organizations that go into the home to check the homes to make sure that these things are taken care of with whatever a community organization or city organization that can help do that. And that's a big deal because once you take away the allergen, kids do very well. So basically, it's really treating asthma appropriately in the outpatient to avoid getting to the hospital. Once a kid is in respiratory distress, meaning breathing fast, having difficulty breathing, and not responding to their medication at home, they should definitely be seen immediately.
So tell us about the process. I mean, you do a lot of work. You're the chief of ambulatory pediatrics, but you also see patients in the hospital. And when you tell this to a child or you tell this to mom and dad, the parents, how do you do it, and how do you make the process, and how has the hospital made the process more user-friendly? I mean, pediatrics is a large portion of Richmond University Medical Center and a lot of hospitals in New York City. But again, there's sort of a specialty right there for it, and the care is really exceptional for kids. So how do you make that process work for mom and dad and the child? And we'll talk about what happens in the hospital, but give me a little bit of a feel what you do with them.
So the continuity, I think, for kids and families in different settings is really the key to good care. And even though in our patient-centered medical home, sometimes we see everybody, it's a lot of work. The fact that we are part of a teaching hospital, that we have residents, that we have specialties that work with us, it really gives us kind of like the entire community that needs to be around that child to give good care.
I'm going to interrupt you. What's a medical home? Because a lot of people don't know that term.
So a medical home is actually a philosophy that we want to practice medicine, especially pediatrics, patient-centered, at the lowest cost to the family as possible, and involving not only the immediate disease, but looking at all the social determinants and everything around that patient that we can work with to make them healthier. And that is something that we do not in isolation within our practice, but working with the community, working with the medical neighborhood. Because a lot of we've developed this work over the last 10 years at our patient-centered medical home, but it's really, we cannot do it alone as physicians. It's very, if you look at medicine, 13% of the health of a person is what we do. Everything else is everything around that patient. So that's how, you have to have that kind of vision. Obviously, it's not perfect. No system is perfect, but, we strive every day to be able to get a little closer to that point. And going back to your question about how do we tell a mother and go to the hospital, so we work in a residency program with specialists. We talk to each other. The pediatric department has a faculty that meets and works with each other and develops systems to kind of like combat the barriers that a patient might see. Thank God we're getting a new ER at Rumsey. Architecture and space really affects not only health in the hospital, but health in people's lives, right? And hopefully that will be an addition. But a building is not enough, and a beautiful building is not enough without good care. So communication between physicians is a big key. So if I see a patient, for example, who's, let's take asthma, which everyone knows about, is wheezing and in respiratory distress, at that moment I treat them to avoid them from getting worse. I make a determination with my team. Can they go home? Can I take care of them? Or can they need to go to the hospital? And that decision we make fairly quickly. If they need to go to the hospital, we actually, in our pediatric department, have created something called like Peds Express, in which if I know that a patient is going to be admitted, I speak to the ER attending, I speak to the attending on service for the floor. I speak to the specialist. We make a plan, and we speak to the residents. And the plan starts when I start, and it goes as they go through the hospital setting, as they go through the ER, as they go through the floor. And sometimes if they're very sick, if they need to go to the ICU. And then when they're done, they come back to me. So it's really communication in a system that's really very aware that a patient cannot be taken care of in silos. You really need to have people talking to each other and an organization within a system that understands that.
So you really want to make the process seamless. So tell us about a parent. Are they allowed to stay over? I mean, we're going to talk about COVID in a few
Yes.
moments.
Yes.
Tell us what mom and dad could do. Could both stay over, one stay over? What do people need to know?
So I think now with COVID, a parent can stay over.
Mm-hmm.
In the past, it was 2. But now with COVID, I think it's 1.
Mm-hmm.
And these things change daily according to the infectivity rate.
Right.
But we'll never have we left a kid without a parent in a pediatric floor, even during COVID. So if it's 1 or 2, it depends what's going on outside and what's happening in the community. But kids see their parents. A parent is a crucial part of the care of a patient for 2 reasons. They have the insight that no one else has on their kid, right? I cannot take care of a kid that I don't know, especially in a hospital setting, because the hospitalist usually takes care of people, like we do service at Rumsey, for example. I do service twice a year, or the 10 of us who are the faculty kind of like rotate.
So service means that you don't know the patient. They just come in from the community.
No, that you cover the floor,
Right.
You cover the floor, and whoever gets admitted, you see. So, when I am that situation, it's not my own patient, which is what happens in medicine too. This is like being a hospitalist, having hospitalists is like the way medicine has gone in many of our hospitals. The person who's going to tell me about this patient is their parents. So, that's a crucial part of it. So we try to make this idea of patient-centered is also bring it to the hospital family-centered, in which the parent is part of the team of decision-making with the team and really an advocate for their child as they go through the process.
And that as an adult neurologist, I mean, I see that also. Getting
with
a
the
history,
elderly.
getting an idea about what the history is, what the patient is really thinking, what's going on at home. And I've had patients with very severe memory problems who say they feel fine when they come in, or people who are having seizures or all kinds of
Exactly.
other problems. And unless the family member, unless that whole team is involved, it's something that can be deleterious to the care of the person if you don't know all that information. Let's jump into COVID. We've actually spent a few minutes not talking about COVID, which is sometimes nice. But how has COVID affected the hospital in itself with regard to pediatrics?
Well, at the beginning of the pandemic, we saw in 2020 we saw many more kids getting admitted to the hospital with COVID. We even had kids in the intensive care unit of different ages, not like the adults, but one kid very sick is one kid too many, because New York City has a relatively high vaccination rate compared to the entire country. It's around above 63% compared to 53% with 2 doses for the nation. And, we are seeing less kids coming into the hospital with COVID. And even in my own practice, right, at the beginning I was seeing, especially like mothers and newborns, right, that when, we get newborns and we would have to arrange for the end of the day with PPE to see mothers and their kids, their newborns that came in that had COVID. So that's like my gauge, right? Because we see a lot of newborns. We probably see, I would say, at least 10 newborns every week in our practice. So now I cannot even think the last time I saw a mother and a child with COVID. I think I saw one in the summer. So I can see the big difference. But we still get kids who have been admitted with COVID in the summer. When it comes to the process, now when you go to the emergency room, if you're going, you get a COVID test, right?
Right.
You cannot be directed to a place in the hospital without getting a COVID test, because you have a specific place to keep isolated any person who has COVID from the rest of the floor, and to keep the PPE that needs to be worn to go into that room and to care for those patients. So that's the first thing that is different from before. So you come in, you're gonna be admitted, you get a COVID test, right? If you're COVID negative, you go into a regular room. If you're COVID positive, you go into an isolation room. So that's what has changed in terms of COVID. And obviously, the fear in parents of a cold, right? A kid had a cold and everyone was like, okay, a kid has a cold. Now a kid has a cold and everyone says had COVID, right? And fortunately, we're able to do COVID testing in our outpatient setting. And I tend to do the COVID testing and also testing for other viruses because, you know, it really has, people want to know that it's not COVID and what they have, especially with ongoing symptoms. So that has changed a little bit. Before someone came with a cold, you treat it symptomatically and you necessarily didn't have to do a test. But now we do because we want to contact trace and we want to minimize people being exposed to COVID by really not missing someone that might have it at any age.
As an expert in this, tell us about the vaccine. So we know as of right now, and this will change, this probably will change in the near future, that children over the age of 12 and everyone over the age of 12 are eligible for the vaccine. Tell us what's your opinion and what do you think about younger children getting the vaccine? So,
you know, you know, my experience and my training in pediatrics has shown me that vaccines are essential for the health of children. It is amazing the difference if you look at how children below the age of 1 are not ending up in the hospital with diarrhea just because we started giving the rotavirus vaccine 10 years ago to every kid from 2 to 6 months of age.
And that's a virus.
Absolutely.
That causes diarrhea.
when I was training in the late 90s, you know, we had a bunch of kids in the hospital with diarrhea.
They get dehydrated.
And get IV fluids, getting procedures done. Once a rotavirus vaccine came into place, I can't even remember the last time I saw a kid with rotavirus diarrhea in the hospital. Going further before my time, something like polio, right? Who knows any kid who had polio, right? Polio has been eradicated because of vaccines. Smallpox, even further down, completely eradicated because of vaccine. An awful disease that disfigured people, that children died from. Even measles. Measles is still a big killer in countries that have not been able to eradicate measles to a certain extent. So, you know, as a pediatrician, vaccines as a tool to continue and give health to children, especially young children, is something that we have done all of our training. COVID is just another vaccine to avoid kids from getting a disease that can put their lives at risk.
And very well said. So clearly you're an advocate for younger people under the age of 12 with the evidence-based medicine.
Absolutely.
When all the data comes out in order to see with regard to that.
Absolutely.
And that's clearly changed all of our lives over the last 2 years, COVID.
Absolutely.
And what's happening with it.
Yeah.
So you mentioned something before that a lot of, I think, our viewers maybe aren't that familiar with. And what that is as an adult, we know that we go to a heart doctor, we go to a neurologist, we go to a stomach doctor for colonoscopies and things like that. But you don't think in pediatrics there are subspecialties.
Yes.
So tell everybody about them. and why would someone go to in the hospital be seen by a heart specialist, a pediatric heart specialist? And tell us a little bit about it.
So for infants, the number one, you know, we always look at rates of mortality. The number one mortality for kids less than 1 is congenital abnormalities, right? And the number one congenital abnormality is heart disease in kids younger than 1. So basically, from the time they're born, we're very hyper aware to make sure that our exams screen kids so we can pick those who have heart disease so they can be immediately taken care of. So pediatrics is backwards from medicine. As a pediatrician and an internist, when I take off my internist hat, I put my pediatric hat, I'm doing completely the opposite. In medicine, I'm taking care of a bunch of people who are sick and I'm trying to find the healthy person. In pediatrics, it's finding a needle in a haystack. I have a bunch of healthy kids and I have to figure out which one is that one needle in that haystack that is sick and that I have to pick out. So it's really a completely different set of tools. So one of the things that's happening in the nursery itself is that in the last few years, we've started to screen for heart disease by taking the oxygen level in one side of the body and the oxygen level on the other side of the body. And if the oxygen levels have to be in certain approximation, and that tells me that your risk of having heart disease is very less, it's very small.
You do like a little pulse oximeter.
A pulse oximeter
where you
on
put
one
the finger
side.
on your finger. We all know about that from COVID
But you
now.
do it in 2 different parts of the body to see because of how congestive heart disease can work. And if that's normal, then we know that your risk of having heart disease is very low, still very high. We keep looking at things as we see them at 2 days of life. We follow them very closely, and that's always in our mind, right? Because we know that's the number one thing. And if someone has that abnormal, we get a cardiologist. So that's one big change in the last few years in terms of screening for heart disease. And you need a cardiologist, but if that is abnormal, or if I hear a heart murmur, or if I don't feel pulses. In an older kid, there's some heart diseases that are a little bit silent, right? And they might manifest at a later time. If there's any signs of that, then we send them to a cardiologist.
There are a lot more treatments now than there were available before.
Yes,
and a lot of things that don't require open heart surgery, a lot of it endovascular, they're able to go through an artery and fix up things.
Yeah.
Not all things, but again, we have a lot more hope with that.
Yeah, exactly. And we have much better technology and better surgeries. It's amazing what can be done to the point that a lot of our kids with heart disease that has been abnormalities that have been repaired as children keep being followed by pediatric cardiologists into their young adulthood, because adult cardiologists have no idea how to take care of repair congenital heart disease. So it's an interesting thing. So basic, and then for teenagers, if there's any symptomatology of another condition where the ventricle of the heart, that this is a hereditary disease, can get big and cause symptoms and put the child at risk. And very few people have that. That's something we are hyper aware during the teenage years when they are doing sports. And anytime a kid comes in for a sports, we are screening for heart disease. We're screening for different things, but mainly heart disease. And if we feel that something is not quite right, we'll send them to cardiology also to get checked. So,
and that's the fear of what happened to a number of very prominent people on Staten Island.
Yes.
And they've been very major advocates for this, of the idea of having sudden death.
Yes.
We've seen that with athletes. We've seen that with high school kids.
Exactly.
The idea of screening them whether it's an electrocardiogram or just listening to their heart or doing echocardiograms really is just so crucial. And I want to say thank you.
You're welcome.
Our half hour went by so quickly. You are a marvelous physician.
Thank
and
you.
Again, the hospital provides tremendous care. And actually, one last point I'll say, because we're always afraid of blood tests and things like that. We only have a few seconds. But the idea of putting an IV in a baby, that still gives me cringes when I was from when I was a resident many years ago. And I think the technology with various, and just for families out there to know, they could use certain ultrasound to see where the vein is.
Yes.
We're not sticking people blindly anymore.
Yes.
And I think where our technology has come up in pediatrics has really been as remarkable as some of the surgical changes and some of the other changes that we see, and that the kids should not be frightened about going to the doctor. Even though wearing a white coat does inspire fear in most of us, it should hopefully be less fearful. And I want to say thank you so much for coming
Thank you so much for inviting me.
And learning so much about pediatrics in the hospital.
Thank you, Allan.
Thank you again.